This is a presentation for the EMS 165B, Section 801, Pathophysiology for Paramedic class for the paramedic program of the College of Southern Nevada. This presentation specifically is going to cover the principle of bulk flow. By the end of this presentation, the student should be able to discuss fluid movement and its relation to capillary and interstitial pressures in the tissues and some diseases that can affect the bulk flow process. The objectives of this program are going to be defining the following terms: bulk flow, colloidal capillary osmotic pressure, capillary hydrostatic pressure, colloidal osmotic pressure, hydrostatic pressures, interstitial colloidal osmotic pressures, interstitial hydrostatic pressures, and an oncotic pressure. Also, compare the relation of fluid movement regarding hydrostatic pressure versus a colloidal osmotic pressure. List the four forces that affect bulk flow. Explain how the four forces of bulk flow affect fluid movement. Explain how changes in these four forces of bulk flow can affect fluid movement. And finally, at the end of this presentation, we will explain how bulk flow is affected within the following diseases: diabetes insipidus, hyperglycemia, liver disease, syndrome of inappropriate antidiuretic hormone secretion, or SIADH, and also pulmonary edema and sacral edema secondary to congestive heart failure. So the first thing I would actually like to discuss would be hydrostatic pressure. When we talk about hydrostatic pressures, what we're actually talking about in a hydrostatic pressure inside the capillary bed or in any situation, but let's just talk about it in general first. A hydrostatic pressure actually is the mechanical pressure exerted on a membrane by fluid. So basically, the hydrostatic pressure is any kind of mechanical pressure exerted on a membrane by fluid itself. Could be water. We're just going to call it fluid in general. So now I want you to go ahead and take a look down here at the picture in the right lower corner of the frame here. And I want you to look at the beaker on the left. In the beaker on the left, you actually have two solutions that are actually been put into this beaker here, and with a selectively permeable membrane, or also known as a semi-permeable membrane. Now, if you look at the beaker on the left, you will actually see that there are two different fluid concentrations in here of fluid and liquids. If you were to actually look at the solution on the left side of the beaker here compared to the right side of the beaker over here, you will see that clearly the solute concentration on the left side is less than the solute concentration on the right side. Now, because of this process right here, because of this situation right here, there is going to be more hydrostatic pressure on this side, on the left side of the beaker, than there is on the right side of the beaker. Now, if you have a higher hydrostatic pressure, what's going to happen is you're actually going to have a higher pushing pressure. Of fluid. If you have a higher pushing pressure of fluid, that means that you're actually going to have more fluid pushed into the right side of the beaker, which will of course result in, if you were to let this sit over time, your fluid level on the left side of the beaker here has actually decreased quite a bit, because all of your fluid, or not all, but some of your fluid actually went into the right side of the beaker. Notice that you didn't move any solutes at all. It was just the fluid movement that actually moved. Now, whenever you actually have movement of fluid on beaker on the left side here, you actually have more fluid going from left to right than you do from right to left. Even though you still do have fluid moving from right to left, most of the fluid is going to move from left to right. Now, in the second beaker on the right side, you actually do have fluid movement. You do have some fluid movement, but the difference is going to be that for every one molecule of fluid that moves from left to right, you have one molecule of fluid or water that moves from right to left as well. So you still have some fluid exchange. Now this is specific to hydrostatic pressure, so that means that you actually have water or fluid pushing against the semipermeable membrane, pushing fluid across the membrane into the other area. Now let's talk about osmotic pressure just a little bit. Osmotic pressure is not really the pushing pressure. It is actually more considered a pulling pressure based on particles within a fluid. Now in this case, the particles themselves is what's actually causing the pressure, as to where in hydrostatic pressure it was the fluid that was actually causing the pressure. So we're going to use the same two beakers down here, but the principle is pretty much going to remain the same. In this case, we actually will have a semipermeable membrane here that is only going to allow fluid, and this we'll just call it water, from the left side of the beaker over to the right side of the beaker itself. Now on the right side of the beaker, since you have more solutes over here, you actually have more particles over here, which means your osmotic pressure is going to be higher on the right side of the beaker than on the left side of the beaker, which means you're going to have a pulling pressure, which is going to allow fluid to come into this area on the right side of the beaker, ending up with the same result. Now in the situation of the beaker here, we actually have high osmotic pressures on the right side and high hydrostatic pressures on the left side. So both of these forces are actually pulling in the direction from left to right, which of course we'll end up with is this situation on the right side of the beaker here, where you have your left side is actually low, your right side is actually high, full of fluid. Now, how does this make a difference whenever we start talking about osmotic pressures in bulk flow and hydrostatic pressures in bulk flow? Well, the first thing I want to talk about is actually something called a colloidal osmotic pressure. When we talk about colloidal osmotic pressures, if you remember correctly, when we talk about osmotic pressures in general, we're actually talking about particle pressures. So the osmotic pressure is the amount of particles that's actually causing the pressure on one side or the other. In this case, in the body, the specific particle that we're talking about is a colloid. Now, a colloid is basically just a protein, and specifically, which protein we're talking about in this case is the most abundant protein that's found in the human body, which is albumin. So albumin in the blood vessel is causing an osmotic pressure. Using this picture right here, this is going to be a cell, this is going to be a cell, this is going to be a cell also. Here's a cell. That's a cell. This is actually a lymph vessel. All of this space here is going to be interstitial space, and this space over here is also going to be interstitial space. The capillary is going through right here, so this area right here is actually going to be the capillary whenever we start talking about this picture. So I just erased everything real quick, and now let's look at colloidal osmotic pressures. When we talk about colloidal osmotic pressures, we're actually talking about an osmotic pressure typically within the blood vessel itself. So within the blood vessel, we're actually going to have lots of little proteins that are inside of this capillary bed causing an osmotic pressure. Now this osmotic pressure is going to cause fluid to be drawn from the interstitial space and have tried to draw fluid into the capillary bed itself. Let's talk about the capillary hydrostatic pressure now. Now, a capillary hydrostatic pressure is basically the fluid pressure inside of the capillary bed itself. Now, the capillary hydrostatic pressure is actually much higher than the hydrostatic pressure out here. So you have your capillary hydrostatic pressure, which is actually very high. This is going to want to push fluid from inside of the blood vessel out into the interstitial space. So this is your capillary hydrostatic pressure. Interstitial hydrostatic pressure comes from the fluid that is being forced out of the capillary bed into the actual interstitial space. You do have an interstitial hydrostatic pressure, but if you were to compare your capillary hydrostatic pressure would win almost every single time in a normal physiologic person. Interstitial hydrostatic pressure needs to remain a little bit low so that it can receive fluid from the capillary bed into the interstitial space. We also have an interstitial colloidal osmotic pressure. The interstitial colloidal osmotic pressure is the pressure that you're actually going to have in the interstitial space. Now, if you remember the colloidal osmotic pressure, the colloid is specifically albumin, which is a specific protein within the body. The osmotic pressure is the pulling pressure itself. So what happens is we have a blood colloidal osmotic pressure, which is actually much higher than the interstitial colloidal osmotic pressure. But we end up with an interstitial colloidal osmotic pressure because sometimes some proteins will leak out of the cell into the interstitial space. Since we have leaking of these proteins into the interstitial space, we then end up with an osmotic pressure in the interstitial space. Since the capillaries actually have their own hydrostatic pressure, what we actually end up with is most of the albumin that we find in our body is typically found within the capillary bed right here. This is going to want to pull fluid back into the capillary bed itself. Remember, we do have an interstitial colloidal osmotic pressure, but the blood colloidal osmotic pressure is always going to be higher. In this case, it's going to be higher, which means it's going to try to pull fluid back into the capillary bed. Hopefully all of that material made a little bit of sense, because now we're actually going to start talking about bulk flow itself. Now I'm going to go ahead and utilize this capillary right here, the same picture. And this capillary up here is going to be the arterial side. And down here at the bottom is actually going to be the venual side, or the venous side, which means blood is actually coming in and traveling from the arterial side up here this direction to the venous side and then out to the veins themselves. Now, whenever the arterial side, on the arterial side, you actually have a higher capillary hydrostatic pressure. You have a very high capillary hydrostatic pressure because on the arterial side, this is actually coming from a high pressure system. So because this is coming from a high pressure system from the left side of the heart, you're actually going to have high levels of capillary hydrostatic pressure. Now, what's going to happen is it's going to push, this hydrostatic pressure is going to push fluid into the interstitial space itself. Because we're talking about a capillary, we're talking about basically a semi-permeable membrane. Now, on this side of the capillary, on the arterial side of the capillary, you also have a blood colloidal osmotic pressure. Because this hydrostatic pressure here is so high, just a few proteins actually do get pushed out of the capillary bed into the interstitial space. Now this all occurs on the arterial side. What happens on the venual side is, if you look at your capillary hydrostatic pressure here, because you're moving further away from the arterial in the high pressure system, what happens is your capillary hydrostatic pressure eventually begins to drop, and it lowers down to a point now where you don't have a lot of force pushing on this capillary wall. But what does happen is, because you're forcing all of the fluid out of the capillary bed as we go along here, what's happening is the colloids, or the albumin, inside of the capillary bed actually become more concentrated. So what you end up with is a whole bunch of albumin over here with very little fluid to actually combat all of this albumin and its oncotic pressure. So what happens is, over here you have a little bit of protein moving into the interstitial space, but as you get closer to the venual side, your blood colloidal osmotic pressure increases in relation to where it was on the arterial side. Because the blood colloidal osmotic pressure increases so much, you then actually have more fluid begin to be pulled back into the vascular system. Now, not all of the fluid that actually leaves the arterial side of the capillary comes back in on the venous side of the capillary. What happens here is that you will actually have some fluid that enters the interstitial space will actually make its way into the lymph vessel. If you remember, this is my lymph vessel. What will happen is you'll have some fluid that will actually enter the lymph system, and then therefore actually become lymphatic system, a lymph fluid. Specifically, it's approximately 15% of the fluid that enters the interstitial space goes into the lymph system. The other 85 or so percent actually enters back into the bloodstream itself. Now let's talk a little bit about diabetes insipidus. Diabetes insipidus is a disorder where there is a decrease in the production and release of something called ADH, which is an antidiuretic hormone. The antidiuretic hormone is actually important in making sure that you retain fluids so that you can maintain bulk flow and hydration of the body. If a patient presents with copious amounts of urine production, for example, in excess of 15 liters per day, they are definitely losing a lot more fluid than they should. The result of this is the plasma developing high concentrations of sodium. What this does inside the capillary bed is it actually increases, because you have higher levels of sodium in the capillary bed, and it could be typically in the kidneys, the patient will actually reabsorb more fluid from the interstitial spaces in the tissues. So in the tissue itself, you'll actually have more fluid reabsorbed because you actually have more sodium inside of the capillary bed. This will dehydrate the area in the interstitial space, and it will bring more fluid into the vascular system, so whenever it actually gets down to the renal system, then it will actually have an abundance of fluid inside the renal system, which will cause the kidneys to excrete more fluid. That's the big problem that we actually have with diabetes insipidus. This results in cellular dehydration and dry mucosal membranes. In hyperglycemia, there is an excess of plasma glucose levels due to either an insulin deficiency or a decreased cellular responsiveness to insulin. High plasma glucose levels increase the osmotic pressure in the capillary bed. If you remember the capillary pressure, or the capillary osmotic pressure, the osmotic pressure in the capillary bed, any osmotic pressure does not have to be albumin. It does not have to be anything other than just a particle. In this case, the particle is not albumin, but it's actually going to be large quantities of glucose, abnormally high large quantities of glucose. Because of these abnormally large quantities of glucose, you actually have fluid is drawn from the interstitial space into the capillary bed because you have an increase in osmotic pressure inside of the capillary bed. Since you have an increase in this osmotic pressure, you have fluid drawn from the interstitial space into the capillary bed. When it gets down to the kidneys themselves, what will happen is all of the excess fluid inside of the capillary bed will then be forced into the kidneys and then actually excreted out of the body. Let's talk about a little bit of liver disease here. Among many other symptoms, liver disease could actually cause something called ascites and peripheral edema. We're going to talk about peripheral edema here in a little bit. What I do want to talk about first is how the ascites actually occur. If you look at the picture down in the bottom right-hand corner of the screen here, you actually have a picture of the intestines and the liver. In a normal person, what will actually happen is you have your intestines down here. What will happen is after you eat something, something will get into your GI tract. As soon as it gets into your GI tract and is broken down, the substrates will actually get into the capillary bed here, into the veins, and it will then travel directly up to the liver itself. Now, it goes directly from the intestinal tract to the liver, because if you drink or eat something that may be poisonous to the body and the liver has the ability to remove that poison or destroy that poison, you want it to go to the liver first if you eat it or drink it. So all fluid and blood and anything, substrates, food that get into the GI tract go straight into the liver itself first. Another thing that the liver is actually responsible for is actually creating or synthesizing the most abundant protein in the body, which of course is albumin. Albumin is important because it transports substances like bilirubin, calcium, progesterone, and helps maintain capillary colloidal osmotic pressures. With liver disease, there is a decrease of blood flow through the liver itself. Now, the liver has a special kind of capillary within the liver itself. These capillaries are actually called sinusoidal capillaries. There are three different types of capillaries, as you can see here: continuous, fenestrated, and sinusoid capillaries. The sinusoid capillaries are important to the liver because you need to have these big holes in the capillary and in the basement membrane right here so that proteins that are actually made can get into and out of the capillaries much easier. It takes a very long time for a protein to try to make its way from outside of a fenestrated capillary to inside of a fenestrated capillary. And it's really difficult down here in a continuous capillary. A protein has lots of trouble getting into a continuous capillary. But if we have these sinusoids, or these holes in the sinusoid capillaries, proteins can actually get in very easily, and that's what we want while we're in the liver. If we have a backup of fluid in the liver itself, or we have a congestion through the liver because of some kind of liver disease, what happens is albumin that gets into the capillaries might not be able to stay in the capillaries because of the increase in the hydrostatic pressure. This will be increasing in the hydrostatic pressure. With these high levels of hydrostatic pressure inside the capillary bed, it is in the liver, it is very easy to push the albumin back out of the capillaries because there's no way for them to stay inside with all of these really big windows inside the sinusoid capillaries. Now, the liver is not really encapsulated in anything like the heart, so there's no pericardium that surrounds the liver at all. So if fluid and albumin is actually pushed out of the liver, then all it can do is, if you look in the capillary or in the caption down here in the bottom left, all the fluid can do and all the albumin can do is actually go into the abdominal compartment itself. Now what happens is, as the liver fails, or as the liver is insufficiently working, all of these albumin molecules, all of these proteins are pushed out of the sinusoid capillary bed. What you're doing is you're actually on the outside of the liver increasing osmotic pressures in the abdominal compartment. Higher osmotic pressure is a higher pulling pressure of fluid, which means it's going to naturally draw more fluid into the abdominal compartment. When this occurs, you then actually end up with ascites inside of the abdominal compartment itself. In the syndrome of inappropriate antidiuretic secretion, or SIADH, what happens in the brain is that there is an excessive amount of the antidiuretic hormone that is released into the bloodstream. This ADH actually travels to the kidneys themselves and causes more retention of fluid within the kidneys, which of course is going to maintain that fluid inside of the capillary bed. Now, if you have high levels of fluid inside of the capillary bed, if you have an increase in fluid, you're also going to have an increase in capillary hydrostatic pressure inside of the capillary bed. What that's going to do is, since you have an increase in hydrostatic pressure, you have an increase of fluid, it's going to cause more fluid to be forced out of the capillary bed into the interstitial space. If more fluid is forced out of the capillary bed into the interstitial space, you could potentially start developing some kind of edema here in the capillary bed. The next thing we're going to talk about is actually congestive heart failure, and two of the problems that go with congestive heart failure, which are pulmonary edema and pedal and sacral edema. First of all, congestive heart failure is a chronic disease process where the right and or left ventricles of the heart fail to efficiently circulate the blood due to an intrinsic mechanical dysfunction. When this process occurs, the blood tends to back up in the heart and the vasculature and become congested, much like a freeway congestion whenever the traffic can't move along due to construction or an accident. Unfortunately, this congestion can cause an increase in the capillary hydrostatic pressure, forcing more fluid out of the capillary bed and into the interstitial space. Since this congestion is due to a failure of the heart, it is called congestive heart failure. Congestive heart failure causes fluid to back up into two major areas we are going to cover: the lungs and the feet or sacrum. First, let's talk about pulmonary edema. When the capillary hydrostatic pressure increases in the pulmonary capillary bed, fluid will be pushed into the interstitial spaces and the capillaries around the alveoli. So if you look in our picture right here, you actually have, this is a capillary, I'll just abbreviate as cap. This is your alveolus, as you can see right here, and all of this orange spongy stuff here is actually the interstitial space. This is all the interstitial space. Now what happens normally is when you start to have an increase in your capillary hydrostatic pressure inside of the capillary bed, what will happen is it will start to push fluid into first the interstitial space. This increase in capillary hydrostatic pressure is very commonly associated with high blood pressure and heart failure. What may happen with something like this, and if you actually take a side view, we're going to have an alveoli over here. If you actually, this part is going to be considered the alveolar duct. If you have a certain amount of fluid that is pushed into the interstitial space, what will happen is it will cause a compression of this alveolar duct, as well as possible compression of the alveoli itself. When this occurs, This could give you the crackling sound whenever someone actually takes a very deep breath who has fluid in the lungs. The crackling sound that you actually hear is millions of alveolar ducts and sacs popping open because of the increase in the inspiratory pressure associated with a deep breath. So when somebody takes a deep breath, you actually have more air pressure that's pushing itself through all of this collapsed alveoli here, and then when it pops open, you actually hear the crackling sound itself. Unfortunately, if the fluid begins to build up in the alveolar sacs, the body could compensate by taking the rings, the muscular rings around the duct, and actually constricting them at the bronchial level. This will actually give you wheezing. This wheezing is actually meant to compensate with increasing the air pressure inside of the alveolar sac in an attempt to keep the fluid that's trying to flow from the interstitial space into the alveolar sac at bay. If the bronchial constriction does not keep the fluid at bay, and if enough fluid can actually make it into the alveolar sac itself, what will happen eventually is it will start, the fluid will actually start to make its way out of the alveolar sac, up into the lungs, and potentially out of the body where it can be expelled or coughed out. Worst case scenarios, you end up with somebody who has what's called a fulminating pulmonary edema, which means that they actually have the pink frothy sputum that's just coming out of their mouth like crazy. When we talk about pedal and sacral edema, when a person has swelling of the feet or in the sacral area of the back in a bedbound patient, the capillary hydrostatic pressure increases in the systemic vasculature. So if somebody has a heart failure, and especially a right-sided heart failure where most of the congestion is backing up into the systemic vascular system, what will happen is, here's your arterial side, and down here is your venous side. The capillary hydrostatic pressure begins to increase back here in the capillary side because you're limiting your return back to the right ventricle itself. Because you have a higher capillary hydrostatic pressure here, even though your osmotic pressure is trying to suck fluid or pull fluid back into the capillary bed, the capillary hydrostatic pressure is pushing on the fluid at the same time. So what's going to happen is you are still going to have fluid moving into the capillary, but what's going to happen is you're going to have less and less fluid moving into the capillary because of this increase in the venule capillary hydrostatic pressure. This causes more fluid to back up in the interstitial space, which of course will lead to swelling and edema. I hope you were able to understand and enjoy this brief presentation of bulk flow. If you do have any questions, please feel free to contact your lecture instructor at any time. Thank you.